Welcome to the latest MS Hear from the Experts webinar. These webinars help people better understand multiple sclerosis, highlight MS-related resources, plus provide tools and tips to navigate their MS journey with more knowledge and confidence. Thank you for joining us for tonight's webinar. I'm Shauna McKinnon, and I'm your moderator for the broadcast. I've had MS for a little over 28 years, and I've been a volunteer with MS Canada and previously the MS Society for about the same amount of time. MS Canada would like to acknowledge that we are on the unceded and ancestral territory of First Nations, Inuit, and Métis people across Canada. These nations have cared for this land from the oceans to the mountain peaks for thousands of years and continue to do so today. We thank them for their continuous care and for the opportunity to host this session today. At MS Canada, we are committed to learning from and working with Indigenous peoples to care for the land we all call home. Before we get started with our presentation, let's briefly go over a couple of housekeeping items. Your microphones have been muted. If you have a question, please type it into the chat box and we will try to get to as many questions as possible following the presentation. We kindly ask that your questions be general in nature so that everyone can benefit from the discussion. If your question is personal or specific to your own situation, we recommend following up directly with your healthcare team or our MS Knowledge Network. This session is being recorded and will be available soon on our website from the Informative Videos on MS page. A Facebook Live recording will be available as well. Please note that MS Canada does not approve, endorse, or recommend any specific product, therapy, or service, but instead provides information to assist individuals in making their own health and wellness decisions. Plus, the views and opinions expressed in the presentations are those of the speaker and may not necessarily reflect the views or positions of MS Canada. Since 1948, we at MS Canada have been proud to be a part of a community of people living with MS, their families, friends, plus volunteers, donors, researchers, clinicians, and many more. Together, we have helped fund research, provide information and support to people affected by MS, and we've taken a bold stance to advocate for changes that allow people living with MS to live full and inclusive lives. Our current strategic plan not only lays out the roadmap in our journey to create a world free of MS, but we hope it also provides inspiration for all in the MS community to connect and collaborate, so together we can advance treatment and care, enhance well-being, understand and halt disease progression, and prevent MS from happening. Please note that during this broadcast, a couple of pop-up polls will appear. We ask that you respond to each one. The anonymous information will help MS Canada better understand your experience and the impact we are having on the MS community. I am pleased to introduce today's expert. Dr. Mark Friedman is currently a professor of medicine in the field of neurology at the University of Ottawa, as well as director of the Multiple Sclerosis Research Unit at the Ottawa Hospital General Campus, and a senior scientist at the Ottawa Hospital Research Institute. Dr. Friedman has spent his career of the past 35 years devoted to uncover the secrets of MS pathophysiology and to find effective treatments. More recently, Dr. Friedman has focused on the use of fluid-based biomarkers to guide treatment. Welcome, Dr. Friedman.
Hello, and thank you very much for this opportunity to speak to everyone tonight. And I'm just looking to see how I get my slides up. There. Oh, okay. I see something. Excellent. Well, as you can see, the title is going to be Some Advances in the Field and Important Changes in, I guess, the way we understand the disease, some of the mechanisms driving them, and that in turn guides our ability to actually develop therapies and ways in which we can discover how therapies work. So with that, I will share, of course, some disclosures and then move away to some, I'm going to call these cartoons, but I think it's important if you just follow through. What we are referring to as the change in the way we perceive MS is really guided by our better understanding of the pathophysiology, how disease comes about, and the biology behind that. And what we see is that there are actually ideas of different stages. And we used to think of MS as stage one was an inflammatory phase. We saw a lot of relapses and new MRI lesions. And eventually this would yield to a progressive phase where relapses became less apparent. You didn't see so much activity on an MRI, and patients steadily worsened with whatever deficits that they had to begin with. We now know that's not true. that although that it appears that there's two different stages, the biology tells us these stages overlap and are there right from the start. So in the greenish type of picture here, the dominant picture early on is of that peripheral, outside the central nervous system inflammation, which drives the attacks, which drives these new lesions from forming. But inside the brain, where all the action is, there's actually this compartmentalized inflammation that is brewing over time and is being given information from cells that come from without. And as that grows, the relapsing phase, which is characterized by those peripheral types of inflammatory activities, goes away, and then the compartmentalized inflammation becomes the dominant picture. But both are very much there from the start. And that's the whole idea here, is that we recognize both processes, and if so, and we understand that both of those processes are going right from the beginning, then to properly treat the disease, one has to focus not on just one, but on both of these. And the most effective therapy is going to have an effect on both of those ideas. So on the left, we have we have the peripheral inflammatory response, and on the right, we have this compartmentalized response. And how do we know the difference between them? And there's some new terminology that I'm just going to throw at you. And if people get worse from the activity on the left, that's what we refer to as the RAW, or the relapse associated worsening. For every attack, it could leave you with a little bit of deficit. You don't heal up completely following the episode, and as a result, you've got you're a little bit worse than you were from the beginning. On the right-hand side, the compartmentalized response is what we were referring to now as the PIRA. How do you get worse there? How do we see that clinically? Is progression, but independent of relapse activity, hence the notion of PIRA. And in a second, I'm going to show you a little bit more of what we're talking about here in some more cartoon form. But that is what we're referring to as the inflammatory, the compartmentalized type of inflammation. Now, there's lots of drivers that push both of these processes forward. And some of those we understand, some of those we can change, and some of them we have no way of changing. Of course, we can't influence genes. The genes are what they are. You're born with what you have, and how your genes react with damage and or the environment through the immune system is something that is guided by genetically some mechanisms that we're only beginning to understand. We can see that on the top left here, there's a bar about lifestyle factors, and those are things that we can do something about. And it's been very clear that some of the things that we take for granted may actually influence how fast this smoldering, compartmentalized inflammation drives forward and makes the disease worse. So something that is seemingly completely unrelated, like smoking, we've seen actually can make the disease worse. So if you stop smoking, theoretically, the disease might actually get better. Exercise has long been known to be important for many, many different types of conditions, and it works well for MS as well. Those people who exercise regularly and maintain well their body health can withstand actually quite a bit more damage before things actually develop. Other things such as obesity and hypertension uncontrolled, or diabetes uncontrolled, all of those things which are amenable to treatments today can be drivers of the smoldering disease. And hence, if we can address those through just good general health and the help of a good general practitioner and keeping those other things at bay, well, then we might be able to influence the smoldering disease. Some things we can't do anything about, like at the very bottom. We haven't figured out how to stop aging, but the aging mechanisms as they go forward lessens our ability to compensate for damage. And that is just a very general kind of thing that happens with aging, be it the brain, the lungs, the heart, the joints, you name it. As we get older, it's harder to withstand injury. When we're younger, we have those abilities. We have those abilities to compensate, and that's key, right? So if you get rid of, if as you age, you lose the ability to compensate. That's where things start to get worse. Now, some interesting new developments around the environment. There's the influence of the immune exposure, which is, of course, driven by what we see in the environment. And one of the biggest triggers may be viruses. And there's a lot of interest now in the Epstein-Barr virus and the family of viruses that may be a trigger for this smoldering type of disease. And ongoing research has been looking at whether that virus plays a role not only in triggering, but maybe perpetuating this compartmentalized disease, driven by parts of the immune system, such as the innate immune system. I talk about innate, there's also the adaptive, but the innate immune system is the natural part of our immune system that is associated with certain cells like microglia cells, and those cells are a part of that smoldering disease. We also know that the B cells and T cells are involved, and that's in the lower right. And at the far right, we talk about the intracellular organelles like the mitochondria, the factories of our cells. The mitochondria are energy-driven organelles. Without the mitochondria, we wouldn't be able to function, period. But it turns out that people who have a worsening demyelination or worsening type of disease, they may have a problem with the way in which those cells manage energy. And understanding how the mitochondria may be affected in MS is a focus of research as well. So that's a very quick, broad view of the smoldering MS. Now, in this particular cartoon, you can see on the natural history of relapses up front, the EDSS scale is on the y-axis, it goes up, and on the x-axis is time. And typically you see this relapsing, remitting phase, and then the relapses are those little peaks, and then they die out in the progressive phase. And what we've learned from more effective therapies today, if you suppress the relapses, as what an effective therapy today would do, you can see that they disappear. But what we seem to expose is this silent progression, this PIRA, that you can see in that sort of orangey line in the middle here. That was there all along. It was hidden by the fact that there were relapses and remissions. But if you remove those, suddenly you expose. And what you see clinically in that seems to be a juxtaposition in maybe a drug that you thought was working. Well, all we did was suppress relapses, but now what we're seeing is progression. You're not seeing the progression. It was there all along, but it was masked by the overlying relapses from that peripheral inflammation. So that sort of exposes some of the mechanisms. And in this particular somewhat complicated diagram, but I wanted to really talk about the 4 things or 5 things that are listed on here, because the rest of this talk sort of revolves around our ability to see these things clinically or with proper imaging and try to get an understanding of what is driving the disease. So to the bottom right is sort of the depiction of the brain with the undulations or sulci of the brains, the dips and valleys. And within there, you can see a few very important things. So starting with number 1 is the focal lesion. And in the very center of that focal lesion is a vein. And around that vein are a series of different cells, part of the immune infiltrate, and they're actually color-coded, and the guide is at the top here. And you can see that there's greens and there's blues, and that's B cells and T cells, and there's those interactions. And then the purple one would be the macrophage. So the perivenular inflammation is what we tend to see as that focal lesion, the lesion that picks up the dye. That's the new sort of inflammation that is forming in the brain. In number 2, some of these pockets of inflammation actually tuck their way into the sulci, or the little valleys on the surface of the brain, and sort of nestle in with the meninges, which are the coverings of the brain. So they're called meningeal infiltrates, or leptomeningeal infiltrates, if you see them in the literature. And in amongst those infiltrates, people have seen in the more progressive phase is, in fact, that these are little follicles like you'd find in a lymph node, and they're made up mostly of those blue cells, which happens to be the B cells. There's some T cells in there as well, but those B cell follicles seem to be something that is seen more in the progressive stage of the MS. Now, as that number one lesion evolves over time, the inflammation in the center dies down. Some of the inflammation that's driven into the brain creates some molecules that can be taken up by the microglia. Those are those purple cells. And one of the products of inflammation that occurs is iron, is a breakdown product of some of the inflammation in the cells. And those microglia eat the iron, and they form a rim around that complex. So that's number three, is what we're going to call the slowly expanding lesion, or the chronic active lesion. And I'll show you the equivalent of that we can actually measure using MRI. Now, once all said and done, the inflammation has died down, you've got this chronic active plaque, there's no more cells going to do any damage. What you're left with is sort of the empty battlefield, if you want to use that analogy. And the cleanup crew is really made up of what are called the gliotic cells. In this case, it would be like the astrocyte. And the astrocyte is depicted there in that star form, and sort of a brownish looking cell with lots of little tentacles all over. And that's a gliotic scar. And you can see these scars form, and it just so happens when they're activated, they release something called GFAP. Keep that in mind, because I will show you some reasons why we would want to measure that later on. So then finally, there's the mechanism that we have to just keep in mind is going on throughout the brain, and that is, as time goes on, you're aging. And exactly how aging affects all of this is unclear, but that is part and parcel of what the brain is doing as we get older. All of these things are driven by an aging process, the inability to repair, the loss of compensation, and eventually you lose brain tissue, and that's just part of normal aging. So just to reiterate these four things that I've talked about here, we've got these focal lesions in the white matter. That's where this perivenular inflammation comes in play. We have the leptomeningeal process on the surface of the brain, where you have these follicles forming with mostly B cells, and we want to be able to get at those follicles. We've got these slowly expanding chronic active lesions where you lose that central inflammation. You've got a rim of microglia around that you can usually pick up by MRI because there's some iron inside it, and that drives some of the MRI signaling. And finally, you've got the gliotic process, which is the scarring process, not unique to MS, but almost any damage of the central nervous system results in the end of with gliosis and microglial activation, as well as astrocytic activation. Okay, so you get worsening symptoms. How do you know what's worsening of the disease? Does it always sort of involve your inability to walk, or walk as fast, or you're slowing down? What are some of the other things that may be telltale signs of this so-called progression independent of relapse? Has become clear that it is not so specific. So patients start to report that it's just taken them a little bit longer to do their typical activities. It's faster than one would expect with an aging process, which would occur over years and years. But now, maybe from month to month, it's taking me twice as long to walk to the mailbox and back. And I'm starting to have more problems with my bladder or my bowel. I didn't have those before, and just I'm just more fatigued. I do a little bit of work, and that would never cause fatigue before. Now suddenly it's causing me fatigue. And then there's all the cognitive complaints that we talk about, which is really a product of our inability to multitask anymore, or be able to do as many things as we had hoped to be able to do. These are subtle, but they're going on constantly, and they may be a telltale sign of this smoldering type of disease or smoldering progression. And that's sort of depicted here, that as as you see, the sort of the green is that relapsing phase, and then the smoldering is that brownish orange as it goes up. When you start to have some of these symptoms that I just described, that may be an indication that this PIRA process is taking over in an individual. What constitutes the PIRA? I just gave you an example of that. The no longer are you getting these relapses or remissions. It's much more subtle. And we don't see that very carefully. We don't see this process directly by looking at the MRI. Because people always think, oh, you look at the MRI, we're going to detect this. I'm worse. I'm going to do an MRI, I'm going to find the answer. You're not going to see that kind of answer. In fact, if anything, the MRI might suggest that things are working because, well, we're not seeing any new lesions form, and we're not seeing any more contrast-enhancing lesions. So how is it I'm getting worse, but my MRI is getting better? And all the MRI was showing you before was that peripheral inflammation, which is natural, by natural history, is dying out here. So that's the PIRA. And this is a very busy slide, but I'm just going to show you some hard data that actually gave us these ideas. You follow a large cohort of patients over time, and during that time, when you're following them, the EDSS score again is on the y-axis, the time axis is on the bottom here. Those peaks that you see are actually, that's a relapse right at the very beginning, and the gray period that is around it is, we're going to call that the peri-relapse period of time. So anything that happens during that peri-relapse time would be considered relapse-associated worsening. But if you see patients in between the relapses and the EDSS goes up, well, that's a PIRA event. And you can see that labeled as a PIRA event. And then you get another relapse. You see how the EDSS went up and then it went back down again. So there was recovery. But now nothing happened in between that relapse and the following one on the far right. You can see there was a relapse, but right after that, the EDSS score started to go up again. And that was, again, a PIRA event because it was outside that relapse period. So we started recognizing that those events actually were driving a lot of the disease process. And if you said, okay, I have a patient who's gotten worse over time, and what we're going to do is we're going to see how many of those PIRA events or how many of the relapse-associated events were driving this worsening to a stage, and we're just going to use a milestone of EDSS-6. So EDSS-6 is that very important stepping stone where you no longer can walk independently. You are requiring at least a cane for walking. That's EDSS-6. And there are three little graphs at the top here that's saying which events were more likely associated with patients who were going from the very first episode, which in this case was a CIS, a clinically isolated syndrome, somebody who may have had just optic neuritis or a spinal cord lesion. They got their first attack of MS, and now we're going to follow them outwards. Over many years, you can see that time at the bottom scale is out to almost 30 years there to the far right, but it was a 20 to 25 year study in this cohort of patients. And when you look at what contributed to the speed at which a patient hit EDSS-6, which of the events were associated with it, right? The first top graph there are PIRA events. The ones in the middle are the relapse-associated worsening. And then actually the far right is something to do with patients actually improving. But in this case, what we're only looking at is what's contributing to the worsening. And clearly it was the number of those PIRA events. That's the gray, that's the patients getting worse faster to hit the EDSS-6. So PIRA and smoldering disease seems to be a big driver. How do we see all this clinically? How does your doctor pick it up? What sort of ways do we have to be able to measure this? Because if we can't measure it and we're trying to treat it, we're never going to know if it gets better. So we need good tools. And I box these into sort of four areas where we're focusing our attention at trying to measure the impact of all of what I've just told you about on this compartmentalized, smoldering central nervous system disease that's driving PIRA. So in the first box, we've got our clinical measures such as the EDSS, and there are a few related types of activities such as walking speed to 25 feet and being able to put pegs into a hole. For some of you who have done that in clinical trials. But we need better measurements. And that's where the second box talks about some of the things that are evolving that help us to maybe get a handle on that PIRA. The third is what we've relied on for years is the imaging biomarkers. And then a field that I'm very excited about at the far right are the fluid biomarkers that may give us an indication of either the process or you're getting or whether we're able to address that process going forward. So with that, let's start with the clinical tools. Now, everybody knows what the EDSS is because it's what we do. It's a translation of the clinical examination that we do each time we're seeing a patient. And that leads to a 10-point scale, which is actually a composite of many subscales that interprets the neurological examination. Everywhere from the far left, which is a perfectly normal patient, to, of course, the far right, where we have no longer a patient. A patient has died. So where are the milestones along here? Between 1 and 0, there's nothing really defined in most patients. At 3, you start to be able to identify someone who's having some difficulty. I already mentioned 6 being a milestone, as these are individuals who no longer can walk without the use of a cane. At 7, you lose the ability to even walk with a walker. At 8, you're pretty well in a wheelchair. So that's the EDSS, a very, very crude method of measuring disability. And what we've learned over time is that it's insensitive. It takes a long time to go from various EDSS steps. And so when you're only doing a study that's saying 2 years, well, the time's a ticking for you to be able to pick up things. We need something better. So what kinds of things are better? Well, I'm not going to go through all the different scales that are being invented to look at this, but there have been ways of assessing cognition. They just take a long time. It takes about half an hour to 45 minutes to do a cognitive test. We have questionnaires we give patients that ask how their symptoms may impact their lives. They're called patient-related outcomes. A long list of questionnaires as how fast you can, walk to the store, or can you brush your teeth? Can you still work? Those are the kinds of questionnaires, but they're also quite crude. So we've been thinking of a different modality, some way of picking up the subtle changes in people that maybe they don't even recognize, and not be so dependent on this EDSS, which is all on the day you come into the clinic and we measure it. If you had a bad day, the EDSS is going to get worse, but it doesn't reflect maybe how you've been doing for the last 6 months or a year. So we've been teaming up with a startup company in Ottawa, which actually, through my colleague Heather McLean, her husband is a computer software engineer, and we were sitting and going, there must be a way of picking this up. And so we've been developing this platform, which we call a gait lab in a shoe, together with the University of Ottawa Kinetics Laboratory, which assesses gait in mostly patients with spinal cord injury. We've gotten these people involved now, and we said maybe there's a way of people just walking, doing whatever they normally do, and not, dependent on their phone or their watch and all those fancy gimmicks that everybody's using that you can easily. We had a study that we thought would be able to pick some of this up. There's this Apple Watch. It measures, how far you walk on a given day. And so, then patients got smart and put it on the dashboard of their car and went, look how many miles I did, and so it's so easy to trick it. We wanted something that was passive, that you just put this stuff in a shoe and walk, do your normal thing. And you don't even know it's collecting data on you. And then it's averaged over time. And all this information gets uploaded to a cloud. And this cloud is actually at the University of Ottawa, where we have these software engineers developing algorithms to say, this is somebody whose walking has been, impaired. And I'm making it very simple for you, but the initial tested period of these insoles, which are as thin as a Dr. Scholl's insole, is like a tiny little thing. You can, they're electronic, so you can just put your shoes onto on a wireless charger, and these things are good for a day. And the idea is that they were picking up some 200 metrics every minute, that about 50 of these metrics per second. And all of this was uploaded to this big software program that the engineers have developed at the University of Ottawa. There were something like 400 different algorithms, and they've whittled it down to about 20 or 30 that are meaningful. And they've come up with a composite, which I don't even understand at this point because it's all sort of computer stuff. But they've tested it. We've tested it repeatedly within our center, and have an ongoing study now with colleagues at Harvard as well as the United Kingdom. And this is, I'm just going to show you some data that we had from some healthy normal people just walking around with these insoles. So you can see on the bottom scale here is days, and on the y-axis is something like the EDSS, but it's a composite score, right? So this is this proprietary composite score. And every red dot here is the individual running a test. And you can see over the course of 100 days, every one of those little green dots stays on the line. But there was one day where all the dots were below the line, and that the computer program flagged it, and then the patient said, "Oh, yeah, you know what? I hurt myself like the day before. I had a strain in my calf," and it picked it up. And we didn't know that, but this software now allows you that if you stubbed your toe or you fell down and hurt your leg, and it's picking up this data that you're somewhat worse, all you have to do is say, by the way, I sprained my leg the other day, and so the state of around this period is not good. Contrast that with another individual who, throughout this entire period here, these are, every one of these green spots is a time when they've measured their gait. This is an individual who, over the course of this period, 1 year period, did not feel there was any change at all in their abilities. But you can see very clearly that these insoles picked up that their gait had been deteriorating steadily over the course of the year. The EDSS in this individual did not change. So we're able to pick up this kind of change in a much more sensitive way, and much faster than waiting for the EDSS to change. I don't want to get into the measures, but we've tested this repeatedly, and hopefully, the company is hoping one day they'll make money on this, but it's in clinical trials right now, and we're using it to try to do some correlations moving forward in a number of different studies. So that's one way of doing it. What about the imaging? Have we improved at all on the MRI? What sort of metrics are there to pick up on some of the lesions that I was telling you about? Well, there are three areas that have been evolving, and a lot of this research actually came from Canada and our colleagues in Montreal at the Montreal Neurological Institute. So the three areas that I'm going to talk about in general are the paramagnetic rim lesions. So on this case, on the far left, if you can see a small little circle, in the center is a dot, which happens to be a central vein, but around that is a rim of darkness. And that darkness is, in fact, the iron that's being picked up on a special sequence of the MRI. That's a paramagnetic rim lesion. So what do you think that represents? Exactly. If you're thinking what I showed you earlier, that's the rim of microglia on a chronic active lesion. One of the keys that we see in the biology of the smoldering disease. At the same time, you may remember the cartoon on the bottom right here, there was this area of the microglia, which were in the center, there was nothing. It was an old lesion, and there were no inflammation anymore. But if you follow it over time, it actually can expand. Now, this is very sophisticated software that is not being done on a routine. The SWI sequence on the far left we can do on a regular MRI, but the one in the middle, slowly expanding lesions, can only be done in proper clinical trials where every single MRI is done on a same standardized platform. And finally, on the far right, we now have nuclear products, which if you use nuclear medicine and you give this injection to an individual, it'll be picked up, it turns out, by the microglia. So we can actually image the microglia, and the TSPO is the marker of the microglia. And don't worry, I'm going to go through these a little bit piece by piece here. So these are the new markers. You can see on the far left the pearl and that rim of microglia where all the arrows are pointing to it. It's around a line in the very center diagram. You can see a black line through the center of it. That's the central vein of the focal lesion. So you can see that the focal lesion eventually becomes a chronic active lesion. And that's seen now on the far right in a phase picture where instead of black, you see it as a white rim. So we can actually measure these pearls, and we recognize the fact that the more pearls you have, the more of these paramagnetic rim lesions you have, the more of those chronic active lesions that you have, and probably the more smoldering disease that you have. So I'm showing you ways in which we might be able to detect this. And if so, if we could reduce some of these signals, we may be able to get at this form of the disease in a little bit better way. So there's your paramagnetic rim lesions. We've seen these associated with worsening of cognition, of inability to walk, and having 4 or more of these is sort of the cutoff. As soon as you have 4 or more of these, you start to see a lot more of the smoldering disease. But pearls are seen throughout the entire spectrum of MS. Even in the asymptomatic stage, you can see pearls, but the more of them you have, the more of this chronic active type of disease that you see, and they're quite specific for MS. Now, you also see that the pearls are kind of getting at the same thing as the slow evolving lesion or slowly expanding lesions, but I told you before, pearls we can measure routinely. Slowly expanding lesions, which are very unique, you need to have a scan that can be absolutely overlapped with each individual scan. That's only done in clinical trials. When you see the clinical trials, we're putting patients with we're putting patients into the MRI machine using a template. The methodology that goes behind it is that we have to be within 1 millimeter of the last measurement. And then you can do these fine sort of calculations where you focus in on one lesion. And that's what I'm showing in the middle here. I can't point to it because this platform doesn't let me do it, but you can see on the one on the far right, there's a red box around that lesion. If you follow it to the left, you can see it's much smaller, but over time it expanded, and we can actually measure that at the very, very far right, how much is expanded. So that's a slowly expanding lesion, but can only be done in clinical trials. Here is actually, if it works, it's supposed to show you time-lapse photography here, but I don't think it's working on this PowerPoint, but you can actually measure these slowly expanding lesions. Okay. Finally, you can measure the rim of microglia using a marker with nuclear medicine. And you pick it up on a PET scan, which is positron emission tomography. The PK1195 happens to be a marker of a neurotransmitter and a drug marker, but it happens to be on microglia, so you can pick it up. There are better markers now because some of them decay a lot slower, and most of the PET markers have a half-life of only minutes or sometimes even seconds, so you have to be able to do the PET scan very quickly after the injection. We're working with a fluorinated molecule that has a half-life of almost a day or two, so that allows us to do more types of analysis with PET. But this is very sophisticated research use only type of analysis, but we can apply it in a clinical trial and pick it up whether or not we're impacting the formation of those microglia. It measures live microglia, whereas the MRI just sort of tells you that they were there. The PET scan tells you this is actually something that is live and happening at that moment. And that's just a measure of the type of PET images that you will see in an individual with MS. On the right, you can see there are many more areas that are involving the microglia activation compared to, on the far left, a healthy control. And then over time, that the PET picks up more of this activity. All right, what about the last phase of measurement here? And this is the area that I think is probably rapidly expanding and giving us a tremendous amount of information, and that is the fluid biomarkers. So the fluid biomarkers can be measured in both blood and CSF. If we're going to do it in spinal fluid, of course, you're not going to want to have multiple lumbar punctures, and so that's probably useful only at the beginning. but you can measure some of these in the blood, and they're absolutely reflective of what goes on in the brain. And so this is a lot of the work that we did here in Ottawa, because I was doing the spinal fluid diagnostics for the hospital for many years and collected all these biosamples, and we were able to look back and say, is there anything that we collected at day one that could predict how patients would do 10, 15, 20 years down the road? And it turns out that if you measure something called neurofilament light chain, which is representative of a structural protein, which is the integrity of the axon. So in the top left, you can see a sort of a broken up neuron. The axon is the wire that then comes out and transmits from one neuron to the other. And if it breaks down, it gives rise to this protein called the neurofilament light chain, and you can measure it in the blood. And you can see on the left, the graph, the higher the level of neurofilament light chain, the higher the EDSS in an individual. So it's very much reflective of this progressive kind of disease. And if you measured it at day 0 and then just followed the patients outwardly, that's what you're seeing on the bottom there. The higher the NFL predicted, those are the patients who are more likely to relapse. Those are the patients in the middle who are more likely to have new MRI lesions. And on the far right, those are the ones who at the highest level are the ones who more rapidly evolve into a progressive phase of disease. So that's the neurofilament light chain. Similarly, there's another marker that I mentioned to you. I'm sorry, I moved too quickly here. I just need to go back. Yeah, there we go. The other marker is glial fibrillary acidic protein. This is an astrocytic protein. So if you remember where the astrocytes come in, and it's near the end, so that's the scarring process. If that is going up, then you're really dealing with more of this profound progressive type of worsening. And that's exactly what you saw here on the far left. This is CDW is confirmed disability worsening. So the higher the GFAP, the higher the CDW. In the middle here, the baseline GFAP, if it's high to begin with, those are individuals who over time are more likely to have progression and also more likely to develop the brain atrophy as depicted there on the far right. Okay, can we get at this using any type of treatment? So we need, there's an out of sync here with this arrow. Okay. I'm gonna click a lot slower, guys. Okay, so it takes a second to make this change. So as I was trying to explain all the focal lesions, we can see these on MRI. The slowly expanding lesion in pearls is representative of the chronic active disease. That's more of what's going on in compartmentalized. So you can see the color coding here, the sort of teal, the focal lesions, the mustardy yellow are the chronic active lesions. And these are the ways in which we can measure them. Now, what about being able to get rid of this type of inflammation? So I'm going to tell you about some of the therapies that are developed. And one of the most sort of advanced stage of this is the idea that we can get something inside the brain that can influence the cells that are taking place in causing some of the smoldering disease. So this is shown here in a cartoon, the microglia, astrocyte, and macrophage. On the outside, we have the B and the T cells and the monocytes. Is there something that can target both of these? Well, it turns out that there may be. And the maybe there is being driven by a possible signal that goes on inside the cell, manifested by an enzyme called Bruton's tyrosine kinase. So if we can look at what cells express Bruton's tyrosine kinase, or BTK, they are now shown with this sort of orange. I can't depict it for you, but hopefully you can see which cells express the BTK, which can now be targeted by a BTK inhibitor. And that is where a lot of the field is going, because we have a whole bunch of these that are now in clinical trials. The idea behind the BTK inhibitor is we've learned that the B cells are stimulating T cells, They are a big driving force, and that's why B cell depleting therapies have been so successful. But this BTK inhibitor can get into the brain and affect the microglia, and that in turn leads to some loss of signal. Just try to get this advanced here. Okay, so in the B cell, it can reduce some of the B cell related formation of follicles and inflammatory cells. And in the microglia inside the brain, it might be able to reduce some of those mediators that are causing the smoldering disease. What do we have? We have all these therapies that I've shown you that you can see that are familiar to you. They're working on the outside of the brain, not the inside, but only the BTK pretty well gets into the brain. On the far bottom right is inside the brain itself, and that's where it can affect the microglia. So there are 6 of these. One of these are probably not going to make it to clinical trials. We just heard exciting news about the one in the middle here. Fenebrutinib is the latest one. It was just finishing and reporting on their clinical trials. We heard about evobrutinib on the far left, that it was not successful in reaching its endpoint to be better than teriflunomide. Tolebrutinib seems to be slowing the progressive phase. It's not very good at reducing the peripheral inflammation. And remibrutinib and orelabrutinib are still in clinical studies, so we don't have top-level data. We only have a little bit from tolebrutinib and most recently fenebrutinib. We don't even have, the abstract hasn't even been presented. And finally, everybody talks about these CAR Ts, so I thought I should at least mention to you what is a CAR T and why are we so excited about it. So just the amazing thing about CAR Ts is you can take the T cell receptor, which is normally on the outside of a T cell, and you can actually cut it off. On the far left, you can see this so-called hinge area. You can remove that actual T cell receptor using an enzyme and put on whatever you want onto the surface. So you can change the T cell. The T cell receptor is how the T cell runs around the body and finds things. So if you take off its receptor, which it was creating to look for something, and put on something that you want it to look for, you've now got an armed warrior with all expressing exactly what you want it to. And then you reinfuse this into an individual, and that CAR T acts like a T cell. It replicates, and now you got many of these CAR Ts all expressing this very important marker, whatever it may be that you want it to attack, and then the body naturally deals with it because these T cells otherwise behave like T cells would do, and if they're targeting something to kill it, well, they'll release certain enzymes that will destroy a cell, and that makes it very interesting because if we wanted to get at those, say, B cell follicles, that are B cells expressing CD19 or 20 inside the brain, we know that the monoclonal antibodies we use to treat the patients that we're giving them now outside don't get inside because their molecules are too big, so they can't get at the B cells in the brain. But if we arm a T cell with a receptor that recognizes the B cell expressing molecule CD19, they'll go into the brain and they'll multiply and they'll take it out. And this technology was developed to treat lymphoma, which is a cancer of the blood. And most of those are caused by B cells. So the first CAR Ts were made with that little armed message on the T cell was an anti-CD19, and this is just showing you during which stage the CD19 is expressed in the developing of the B cell, because the cancer could be anywhere along that lineage. But you can put whatever you want onto the surface of a T cell. If we knew which antigen or which molecule was the target of MS, we could arm a T cell and have it do what we want it to do. And then what it will do is get inside the brain and attack these follicles. And this is just showing you an example of, say, a B cell that has, it happens to have EBV. And the reason why EBV is mentioned in here is because Epstein-Barr virus lives inside of the B cells of our body. And then you have this reaction with the CAR T that will remove those B cells. Now, does that matter? I can tell you we're in the infancy of testing this CAR T technology in MS. It's been used in refractory lupus. And in lupus, it's actually done quite a bit. And that's what makes us very excited to try it in MS. And the notion here is that you've got these antibodies, ocrelizumab and rituximab and ofatumumab and ublituximab, and all of those drugs work outside the brain on the left, where it says periphery, but they can't get inside to attack those follicles. So what can we do to do that? This is where the CAR T would come in, because it can get in there, and it can now, if it's armed with an anti-CD19 to knock out B cells, it can knock that out. Now, it doesn't have to be CD19. There are lots of different B cell expressing antigens, and one of them is B cell maturation antigen, and some of the newer CAR Ts are actually looking at a bispecific. So you can put CD19 and an anti B cell maturation antigen and put it into clinical studies. So in fact, these are all the list of clinical studies that are ongoing right now at clinicaltrials.gov. They're very tedious studies to do because it costs, upwards of $100,000 just to make enough CAR T cells for one infusion in an individual, just because of how complex it is. But I think, the results can be quite exciting. And this is data like literally hot off the presses from, believe it or not, Wuhan, China, where they have a big CAR T program. And what I'm showing you here on the far right, and I don't want people to get too excited, these are 5 patients with progressive MS. Actually, one of them had relapsing disease, and the other one had primary progressive disease. But the point is, this was a bispecific CAR T that they made using the B cell maturation antigen. And if you can see these graphs, they have the same sort of patterns as I had shown you earlier. The little ups and downs are relapses, and then the EDSS was going up, and you can see these patients were progressing. And then near the right 2/3 of these graphs, you could see that they got the CAR T cells at the top there, and that as your time goes on, those patients actually, their EDSS went down. So it improved. And if that's the case, that can be shown in a larger clinical study. All I can say is, wow, that would be amazing. And this is very early and very encouraging data, but very, very early and precocious. So let me conclude, because I was hoping to finish a little bit earlier, and I didn't expect a 10-minute introduction. But anyways, this is a progressive disease from the start. The drivers are a combination of peripheral and compartmentalized centralized inflammation. We need to get at both in order to address the disease. I told you about a family of drugs now that are being developed that may be able to do just that, the BTK inhibitors, and then the very exciting new field of CAR T technology that probably will take a good 4 or 5 years before we start to see any major developments. And with that, I will stop, and I believe we have time for questions and answers. And I don't have a hard cutoff at 7, but maybe the MS Canada does. If you don't, I'm happy to stick around.
Okay, I think we can spare a few extra minutes here, Dr. Friedman. Thank you so much. I've got a million questions going through my own head right now, but we are taking questions from audience members. They can type their questions into the chat box. We're going to cover as many as possible. One of the questions that came to my mind as I was listening to you was thinking about my own treatment of DMTs, and there are a lot of people who are on DMTs and have been for a number of years, and many of us have been told that at some point you'll be able to stop taking the DMT. But what I'm wondering now, some neurologists are saying, no, stay on it as long as you can. Is that because once you're off the DMT, you are no longer going to be masking that PIRA?
Well, you're masking it in the sense that it's happening, but you're just not seeing it. That's like putting on a blinder and going, no, I don't see anything. It's actually happening, right? So yeah. The reason why we think you can stop it is because at some point, since all of those DMTs that we have today, with very few exceptions, address the peripheral inflammation characterizing the more earlier stages of MS. And at some point, that inflammation is no longer the dominant force. You're not having any attacks. There's no new lesions being formed, but the PIRA seems to be climbing. So it's not addressing the question at hand, the process at hand. And some of those DMTs, I mean, the early ones are so safe, you could probably take them a lifetime and it wouldn't make a difference. But the ones that have been developed later, the more potent ones, they carry risks as you get older. And as you get older, your immune system gets older as well and doesn't work as well. We know that. Just think back at COVID. Who are the people who are getting the sickest fastest? And that's with the older folks, unfortunately. So immunosenescence is what we refer to that as. And now you've got a DMT that has never been proven in an old person to do anything. All the studies are in younger folks anyways. But that DMT now has the potential for more harm because it's compromising further your immune system, and your immune system gets compromised just from aging. It may be putting you at undue risk for more problems, but not really offering you any benefit. So that's where that benefit risk ratio starts to flip. And if my patients have been stable on their DMT for 5 or 10 years and they hit age 60, I tell them, listen, it's probably not doing anything for you. At this stage, it might actually be causing some problem. Why don't you just get off it? And most of those patients have been able to stop it without any problems whatsoever.
Okay, thank you. From our audience here, somebody's asking, how often should NFL measurements be taken to assess disease progression?
Well, it's not a great marker for progression. GFAP would be a better marker, and it's just working its way into clinics now. The NFL is much more reflective of new inflammation. It predicts new inflammation, it predicts new MRI lesions, it tells you which patients are at risk of early progression, and it's a marker that takes a while to get out of the brain and into the blood and seems to last about 3 months. So if you've had an attack and the NFL is high, it's not going to go down in a day. It's going to take about 3 months to come down. So ideally, if you wanted to measure it and cover a year, we tell patients every 3 months.
Okay.
GFAP.
Knowledge translation to the front line for, say, family doctors or physiotherapists or nurse practitioners. Are there any initiatives underway to improve awareness of early signs to get people into screening with a neurologist earlier, especially when there's no known family history and therefore awareness of MS being a possibility?
That's a great question. I've tried for years to teach the family doctors, and it's gotten harder and harder. I just don't think they want to be taught about MS. But having said that, we now have new criteria for diagnosing MS with just an MRI. So it means we can pick up asymptomatic disease. Patients used to ask me, well, my daughter's 25 and she's complaining of fatigue. I don't want to get her scared, but should I do an MRI on her? Is it even worth it? I would have said years ago, nah, don't bother, because whatever we're going to pick up, it's going to be asymptomatic disease and we can't make a diagnosis. Today, if that MRI has the characteristics of lesions that are absolutely MS, and there are now criteria that define that we could make that diagnosis. Now, what you want to do with it is another question, but we have the opportunity, if you can make a correct diagnosis early, to offer treatment. So I think my whole mindset has changed now that we have criteria that can actually diagnose asymptomatic disease.
Okay, you touched on this a little bit about the Roche's fenebrutinib. You can say that for me. This is a new word for me. The Roche's fenebrutinib.
Yes, the fenebrutinib is one of the 5 BTK inhibitors that are in clinical study.
Right. Maybe you can go over that one again.
They had two parallel studies in relapsing disease, and they had one in primary progressive disease. The two in relapsing disease faced off against teriflunomide, and their primary outcome was to show that they were better at reducing relapses and MRI lesions compared with teriflunomide. And so they hit their primary endpoint. We've not seen I've seen the data because I'm an investigator, but they have not been publicly presented. In fact, it's going to be presented in a week or two at the American Academy meeting. So they hit their primary endpoint, but we've got drugs that work very well on relapses and MRI. I mean, if it's not going to do anything for progression, I really have a question as to what the role of that expensive drug will be. And it really wasn't much better than teriflunomide on progression, so we're hearing. But we'll have to wait till we see the data. The other study was in primary progressive MS, and what they did was they randomized patients who were on ocrelizumab for primary progressive versus fenebrutinib, which was a daily pill. And they said, is there going to be any difference? And initially they postulated that it would be better, and then about halfway through the study they changed their mind, and they could do that because they never looked at the data and said, you know what, let's just call it a non-inferiority trial, meaning we're not going to be any worse than ocrelizumab. And so they hit their primary endpoint in the sense that they were not any worse than ocrelizumab. What is going to happen with that data, I don't know. Would people rather take a pill every day than to come in for an infusion every 6 months? One of the problems with the pills and this whole family of drugs is it can cause severe liver toxicity, and how you mitigate against that early on is going to be one of the ways in which these drugs are going to be carefully put into the marketplace.
Okay, I think we've got time for one more question here, and this has to do with your discussion about the gait sensors. Are there more areas in the country that use this testing to try, for example, in Saskatchewan? And are there any studies going on that people could join?
Well, right now, again, it's in its infancy. This is something that's being developed by a very small software company in Ottawa that has gotten some backing from a philanthropic millionaire who happened to be from Ottawa, is a Welsh billionaire, and he wanted to do something for mankind. And turns out that his employer Bruce is married to one of my colleagues, and this is how we started talking. Anyways, we've done 5 or 6 years of this development. I don't think anyone's as advanced as us in terms of the development of this insole. Full disclosure, I have no proprietary interest in this company whatsoever, but I have a very strong interest in trying to find a cure and treat multiple sclerosis, and I've been frustrated by the insensitivity of our measures, such as the EDSS. Hence, let's use this wonderful AI technology today and develop a sensor that will pick up passively how a patient manages on a daily basis, and not just reflect on the one day every 6 months that they happen to show up in the office and I do a test on them. I'd like to understand what's happened to them throughout their entire last 6 months or a year or however long this spans. And what we've seen is that all the patient has to do is wear these insoles for 3 minutes a week, and it collects the data prospectively and passively. All you need is a phone, because that's how the information gets transmitted from the insoles to the cloud. And you don't even have to have full connectivity to Wi-Fi all the time, because it stores it in the phone, and as soon as you have Wi-Fi connectivity, up it goes to the cloud, goes straight to the University of Ottawa. They analyze it and they give it a number. The testing out of Harvard and the UK have shown us that this is a very feasible way of being able to do this, and it may have applications well beyond MS. My colleagues are starting to use them in Parkinson's disease, for instance. The UK was very interested in them because they thought that if they just got elderly people to walk around in it, they would see which patients are more at risk of falling and breaking a hip. So it has some universality to it, and it's currently in a couple of neurological trials to see if it's any better than what we currently use, such as the EDSS, and I think it will be. But the trials, the person's asking, I'd love to get the rehab folks out in Saskatoon interested in it, but it's just a small company, and they have just made the insoles enough to do these clinical trials. Of course, they hope to be able to patent it and sell it and all that kind of thing. And And I think if that person is interested, there will be. I think they've got a booth at the American Academy. I think they've got another one coming up at the consortium meeting down in Charlotte for the CMSC. So you'll hear more about this type of technology, and this is Canadian born, so I'm very proud of it. That'll be hopefully it'll be the future for us.
Excellent. Dr. Friedman, we've come to the end of our time here. Thank you so much for being here. Fascinated by all of this information, as always. And now I have more questions rolling around in my head. And as we wrap up today's broadcast, I want to remind everybody about how you can connect with the MS Knowledge Network, which is staffed by trained navigators who provide consistent, quality information and support. You can connect by phone or email or live chat through the MS Canada website. Navigators are available Monday to Friday from 8 a.m. to 8 p.m. Eastern and can provide assistance in both English and French. We'd also like you to be a part of the MS community, encourage you to get involved with our programs, services, events, government relations, and volunteer opportunities. Together, we can take action to create a future free of MS. To find out more or find out how you can take action, just check out our website at mscanada.ca. If you have questions about any of our education activities, please reach out to education@mscanada.ca or visit our website. On behalf of MS Canada, we thank you for joining us today. Goodbye.